Okay, so I know we recently have had a lot of new members to our club, so I want to quickly go over updates because we've had a lot of questions regarding this. So first of all, I want to thank everybody who made the time in their schedule to come out to join us live here. A common question that's been confusing for people is to kind of see if they can get verification for this, and we do offer verification for this call. So and the way that you can get those verification is by watching this call to the end and writing us a summary. That's important. And regarding the summary, all details are posted in our Instagram bio. So here I'll quickly go through that. So if you go to our Instagram bio and click on the link tree, and then we keep everything. If you want to know how to put this on your resume or how to put this on applications, regarding where to send summaries, there's an email that is at the bottom of this slideshow. It's clubmedshoe@gmail.com. So this is where you will send your summary. So if this is your first time here, I would highly recommend that you go through this. It'll clarify things up for you. So that'll be good. And then if we go back, and we recently also started a volunteering section to our club. So if you go follow official clubmed.volunteering, we have opportunities for everybody. So if you click on the volunteering link tree, like it says, please read the guidelines. Everything that you need to know about how to get into volunteering is right here, and all the questions that you have regarding what we have different programs. If you want to go check it out, if that's something you're interested in, you want to volunteer and it's been difficult due to COVID, you haven't been able to go out and do stuff. So this is a perfect way to do stuff from home, and everything is accounted for. So if you have any questions, go under there. But if you're confused about anything through all of this, you can always DM us on our Instagram, and we'll quickly reply. We'll try to quickly as possible reply it, or you could also email us. And yeah, and then we'll get into the call. So today we have a very exciting call with Joel, who is a board certified physician assistant. He is in surgical and clinical ophthalmology. He's also a professor of ophthalmologist, and I will let Joel quickly introduce himself. And Joel?
All right, hopefully you guys can hear me and see me okay. My apologies first, I'm recovering from a cold, so hopefully I sound okay. So yeah, my name is Joel. I'm a board certified physician assistant. I graduated PA school in 2019, so I've been out as a PA for over a year. I first started working in family medicine as a PA because PAs in ophthalmology are extremely rare. It is very uncommon. And so because it's uncommon, it's hard to find a position for one. So I did primary care family medicine first, and then I finally found a position in ophthalmology because that was always my goal. And I've been doing ophthalmology now for the last several months. And I work both in the surgery 2 days a week and clinic 2 days a week, and I have 1 day off. So a nice blend of clinic and surgery. I can share more about my background. We can do maybe that at the end, and I'll just get into ophthalmology, the topic. We're going to go over just some basic anatomy review. I'm not going to make this complicated, but the eye is a really intimidating organ for a lot of people. We're taught to avoid the eye and to not touch the eye. And so a lot of people don't know about it. And so I find it's good to just have a basic synopsis of the anatomy so you know where and what we're talking about. And then I have a lot of videos. I'm a visual learner, and so I find videos are helpful. The nice thing too, ophthalmology, we're obviously a visual field. We take care of vision, but it's very visual. And so if you're a visual learner, you might excel in this field. So I have a lot of videos to show you our exam techniques and then a procedure that we commonly do for 2 conditions that I will be talking about today. So let's jump right in, and feel free to ask questions and we'll answer them as we go through the meeting today, okay? So let me share my screen here.
Go ahead. If you have any questions, just put it in the chat, and then we'll look at that and we can go as we go. Okay, Joel, you can screen.
And do you see my screen or no?
No. Yeah, there you go.
Now, okay. So you should be looking at my Word document here. basic anatomy. So the way I like to do anatomy for the eye is in two options. You can either do it from the front to the back, or you can break it up into 3 different sections. So I prefer the latter, the second option, but we'll go through the front. So the front of the eye, you have the orbits, which would be like out here, the bone, kind of that area. Then you have your lids and your eyelashes, your cornea, which is this part right here, the front of the eye, very just clear, transparent piece of tissue. The conjunctiva, the sclera is the white part of our eyes. Then you come into here called the anterior chamber. It's this open space, and that's filled with this aqueous humor. It's a fluid. And then you have your iris, the colored part of the eye, the pupil, that's our black part of our eye, and that's kind of the window to the rest of the back of the eye. Then you have the lens, which is right here, and that sits in this little capsule. Then you have the posterior part of the eye. This whole space is filled with a gel called vitreous gel. And then you have the optic nerve, which is back here. The optic nerve, what you're actually looking at is part of the brain. So this connects up to the brain. So it's pretty cool that on your eye exam, you get to visualize the brain a little bit. And then you have the retina. And on the retina, you have the macula, which is right here. That little dip is called the fovea. That is in charge of the center part of our vision. So whenever patients complain of like central vision loss, you need to think macula because the macula helps us see centrally, whereas the optic nerve helps us with our peripheral vision. And then the retina is just really vascular, full of vessels and arteries. The other option to think of the anatomy is 3 different sections. So you have like a front section, a middle section, and a back. So the front would just primarily focus on this area here. And then the middle section is here, the lens, and then the ciliary body. And then the posterior segment back here. So in ophthalmology, you can subspecialize within ophthalmology. So ophthalmology is a specialty. Well, you can even specialize within a specialty. So you have ophthalmologists who specialize on just the cornea. You have ophthalmologists who mainly just do cataract surgery, which is where this segment here, the lens is. We're all born with the lens. As we age, we develop a cataract. That's where that forms. You have ophthalmologists who specialize in the retina, which is back here. You have ophthalmologists who specialize in glaucoma, which affects the optic nerve. So very specialized fields and very high yields on anatomy. So if you can kind of have a general idea of what the anatomy is and what things do, that helps you understand a patient's complaint really well. The other part of the anatomy is we have extraocular muscles, EOMs for short. So these, I only put them on here. I didn't know like what type of audience I have, if there's high schoolers or med students or even current PAs or current med students. I put them on here because I was asked these on my board exam, like all of them. And I was like, oh, maybe they'll want to know. So we all have 6 muscles, eye muscles that help move our eye up, down, left, right, and then diagonally. That's how we move. So if someone has what in layman's term, a lazy eye, one of their eye muscles doesn't work properly. So you could memorize these. For example, the lateral rectus eye muscle moves your eye laterally, and that's controlled by your cranial nerve abducens. That's a fancy like way to remember it. I created this like chemical equation. So for those of you in high school, if you're doing like general chemistry or college and you're doing like stoichiometry, if that rings a bell, I remembered them by creating this equation. So LR6, LR stands for lateral rectus, with the 6 stands for cranial nerve abducens 6. SO4 stands for superior oblique. Your cranial nerve 4, the trochlear nerve, moves that eye muscle. And then EE stands for everything else. So all these other muscles are controlled by cranial nerve 3. So, and then these are side notes. Cranial nerve 3 also opens your eyes, and cranial nerve 7 closes your eye. So for example, if your patient has an inability to close their eye, and you've guys heard of like Bell's palsy, well, that's because Bell's palsy affects cranial nerve 7. Or I have patients who have a nerve palsy, and I can figure out which nerve they have a palsy based off their eye and where it's located. But hopefully this little equation will really help you remember them. It really helped me on boards when I was asked again every single one of these, and I just had to remember that equation and I knew what it was doing. I didn't have to memorize each little thing. So hopefully that helps. Okay, so in ophthalmology, what I love, guys, it's fantastic. In clinic, I get to visualize a patient's symptoms and exam findings with my own eyes right in clinic. in primary care, where I first started family medicine, I'm listening to patients' heart and lungs. Well, then I had to go send them out for like a chest x-ray, and I had to wait for the results and wait for the interpretation. It was super annoying. It's a hassle. Whereas in the clinic, I can talk to a patient and I can just whip this machine over called the slit lamp. And that's how I do my eye exam. And I can right then and there in clinic visualize with my own eyes. I don't have to order imaging, although we do a lot of that and you'll see that. But it's super fantastic to be able to visualize pathology. So a slit lamp, if you see this image here, the patient, they put their chin in this chin rest and their forehead up on this bar. Hopefully, can you guys see that black line pretty good on the slit lamp here? Or do you want me to zoom in?
You can zoom in a little bit. It's a little small.
Okay. Let me know if that black line comes in better.
Yeah, I can see it now.
Okay, so the key thing with these slit lamp exams, you guys, is the patient has to be aligned in order to do this well. So you want the patient's eye to align up on where that black line is. So forehead on the bar, chin in the chin rest, their eye needs aligned up there. They can put their hands on this handle. There's one on this side. You as the provider, you're going to be on this end. So think of this like a video game. This is a microscope with a bunch of different lights and different filters. We do a lot of optics in ophthalmology. I will put my one hand on this right here and another hand on this joystick. This whole microscope is on this table that moves left and right, and it can go forwards and backwards. So that's for like big gross movement. The joystick here, that is for fine movement. So I can like fine tune up and down or left and right, focus in and out. And then your eyes are going to look through these microscope here. So just like when you're in lab, the key thing is to figure out what your pupillary distance is. In other words, you just want them to line up to how far your pupils are distanced from each other. And then two, you can do this one of two ways. Either you can wear, if you wear glasses or contacts, if you have a prescription, you can either wear your glasses and contacts and then set these to just nothing, or you can either put your prescription in here and then not wear your contacts and glasses. Most people just wear their glasses or contacts and then they have it set at nothing, but you have that as an option too. This also magnifies, and then this little guy, this lens here, that's what I use to look in the back of the eye. So if we recall, when I come up here to our eye anatomy chart, when I use that slit lamp, I can look at the front of the eye really well. But what was our window to the back of the eye? Do you guys remember? That was the pupil. And in an undilated pupil, this little round pupil, my window is really tiny. I don't get a good view. So how do I get a good view? Well, we dilate their eye. When we dilate our eyes, the pupil gets bigger, therefore my window gets bigger. Also, when you do eye exams, you're using a light source. And what happens when we shine a light on our eyes? Our pupil constricts, right? Well, when we dilate, it paralyzes that muscle, so it doesn't react to the light. So that is how I get to look in the back of the eye. And when I do that, I have to use this special lens right here. I have videos coming up that will show you what your view is when you're examining a patient's eyes through that machine, okay? The other way to look in the back of the eye is called indirect ophthalmoscopy, which is this picture. So you're gonna have the patient, you're gonna lean them down flat. I wear this headpiece. I set the pupillary distance, it shines the light, and then I hold this other lens and I hold that in front of their eye, and that helps me examine more of the retina and more of the periphery of the retina. Again, there's going to be a video that shows you what this looks like. So these techniques are not taught truly, like even in medical school. So like if those of you want to go to medical school and you're interested in ophthalmology, I didn't go to med school, but from what I've heard, most even med students aren't exposed to ophthalmology. You might have like one or two lectures, but it's definitely a field that you yourself kind of advocate for yourself to get into. And it's not really until ophthalmology residency that you start learning ophthalmology. So same thing in PA school. We're not taught any of this. I had to learn it on the job. I also come from an ophthalmology background prior to PA school, so that's how I learned a lot as well. That said, go ahead.
Really quickly, Joel. So you said that like it's you're not really exposed to the ophthalmology field as much. So could you talk about specifically about yourself, like what kind of things that you did to get involved in ophthalmology? Because I see that as a common question in the chat.
Okay, yeah, great question, guys. So I didn't know I wanted to do ophthalmology until I started doing it. Well, how did I get into it? I wanted to go to PA school. And to go to PA school, you have to have hours of healthcare experience to apply. So if those of you in high school or in undergrad and you're trying to get hours, consider doing an eye clinic. And here's why. So in ophthalmology, they have a really team-oriented field. So you have the doctor who sees patients, but you often have a scribe. You often have a technician that does a lot of the initial workup for the provider. So they're the ones checking the patient's vision, their eye pressure, and other things. You have people doing imaging, and you have a lot of techs helping with procedures. So for me, when I was an undergrad and I needed hours of experience, I didn't really want to pay a lot of money to go get a certification in like a medical assistant or a CNA or EMT, because I'm already paying money for a 4-year. So I went to an eye clinic, and a lot of eye clinic technicians are truly trained on the job, a lot of it. So it's a great option for those of you who are looking for healthcare experience. This doesn't mean you have to stay in ophthalmology, but it's an option where you don't have to pay to go learn. You'll get paid to learn, and you can do a lot because these clinics are very known, and it's really well acquainted with training someone from ground zero. Guys, I literally knew nothing about ophthalmology, nothing, ground zero. And they took a kid who knew nothing, and I worked in clinic. I helped with all their imaging. Then I became a scribe, which is super helpful when you go to school. And then I learned how to work up the patients. And then they even threw me in surgery. So then I started first assisting in surgery. And so I already went in PA school knowing how to do surgery, and like the whole sterile and gowning and gloving, all that. So it's a good option if you're trying to figure out if this is a field for you. Do it. Don't just think about it, but maybe actually do it. And that's where you're kind of turn your imagination of medicine and actualize it into something real. And you'll see medicine maybe isn't what we always imagined it to be, but in a lot of ways it's rewarding still. So does that answer people's questions?
Yeah. So just if that's something, ophthalmology is something, a field that is interesting, I mean, the best step to start is by working in an eye field.
Yeah.
Eye clinic. I mean, that's your best step to go for, and then you will grow within that job, and you'll get to know more about the field. And that's, I mean, not only, you don't have to necessarily like it, but it'll give you what you like about it and what you don't like about it. And the earlier you get into it, I would say the better it is. So you can kind of get to know the pros and cons of the field in itself, and that's the best way to start.
Exactly. 100%, you guys. Like, truly, even though it's a specialized medicine, there was things I learned in ophthalmology that transcended to any field. So it's not, don't feel like you're narrowing yourself. You will learn things that you'll carry with you in any field you end up in. But if you find it exciting, it's only going to validate that. So it's a good field if you're a visual learner, if you're very hands-on. It's a very hands-on clinic. I mean, you see our exams are hands-on. I'm using lights and instruments and tools. We order a lot of in-house imaging, which is fantastic. I don't have to order things outside and wait for results. I just do it right in clinic. It's very rewarding. You're taking care of vision. And then it's really like just a good quality of life for the doctor and provider side. And I can get more into that later. All right. Are we going to move on, or is there more questions?
Go ahead.
Okay. So we're going to show some videos now of these two techniques. So again, the first one's called the slit lamp exam, and then this one is the indirect ophthalmoscopy. So let's go here. Now, pardon, my clinic doesn't allow me to like record patients. And so I couldn't use like my own actual videos, but these are from YouTube. So this is a slit lamp view of, and we're looking at the front of the eye, and this patient, they have a condition called HSV keratitis, so herpes simplex. So they have herpes in their eye. And you're going to see a view here of, I'll talk you through it. So when you're at that machine, this is what I get to visualize in view. Oh no, it stopped there. Okay, cool. Is it still going for you guys?
Yeah, that's good.
Okay, good. So you guys see here this gray, do you see my cursor hovering over this gray area? That's not supposed to be there. The cornea, again, is really clear and transparent. Now your cornea, it helps with anatomy. It's made of a lot of nerve endings. So just as if I were to cut my skin, I feel that, right? Well, your cornea, because it's very sensitive because of those nerve endings, anything you have in your cornea is going to produce pain because your patient's going to feel it. Your eye is going to communicate to your body like, oh, something's in my eye, because when your cornea blinks, it's going to feel that. So it has this like foreign body sensation. Your eye then is going to say, oh, let's produce tears to flush that out. So patients are going to come in with pain, foreign body sensation, and tearing because their body's trying to flush it out, but there's nothing to flush out. It's stuck there. They're also going to complain of light sensitivity and vision changes. So this is the virus on the cornea, and you'll see here, I'm going to skip up ahead. So when we examine the cornea, I use this special dye called fluorescein. Fluorescein is this yellow orange dye, and I put a drop of that dye in the cobalt blue light. So a special blue light that shows where this fluorescein dye will stain the cornea. So you'll see here, with this person, they added that orange yellow drop, and you see here on the exam now, that gray area that we're talking about, is now yellow. And that's because this dye really highlights the areas where it uptakes the dye, if that makes sense. So it should zoom, it should be clear here in a second. They should zoom in, yeah. So that gray area is now this yellow dye here that we're talking about. All this dye up here, that's because now this person has a corneal ulcer, which is even like really bad. Probably this patient was given topical steroids, eye drops that are steroids, and it caused the ulcer. But this here is called a dendrite. That's a very classic presentation for this herpes simplex virus in their eye. So anyways, it's a cool exam technique that we get to look at and visualize. You can kind of see it better there when you're looking at the front of the eye there. So they have a corneal ulcer with a viral herpes right in their eye. So that's a slit lamp exam. Let me exit this video. Looking here, I just wanted to show another view through the slit lamp to look at cataract. So again, cataract was that middle portion of the eye. Here, there's different types of cataracts. This person has a nuclear cataract. So my cursor is kind of hovering over it. So this beam is turned at a 45-degree angle. This beam here is looking at the cornea. This black space, that's that anterior chamber we talked about where there's that fluid. This is now looking at the lens. And this yellowing, that's called nuclear sclerosis. It's a type of cataract. They're going to do a technique here called retroillumination. Sorry, I'm using fancy terms, but it's to look kind of behind. And now you see this kind of cloudy circle ring. Do you guys see that? That's called PSC right here. So you see all that? PSC is called a posterior subcapsular cataract, another fancy term. But basically, let me get out of this. Do you see me when I'm talking, or do you just see my screen?
I see both.
Okay, perfect. Okay, so the way I teach cataracts is think of a peanut M&M. You guys know M&Ms, right? They're delicious. So your cataract is the lens that we're all given at birth, and our lens sits inside this capsule. So think of the cataract as the peanut M&M and an M&M, and that chocolate is this capsule coating. And so this person, they have this cataract, this peanut basically inside this capsule. When we do cataract surgery, we make an incision through that capsule and we suck out the cataract, and then we put a new man-made lens in. And you only have to have cataract surgery once, but everyone gets cataract. So this is just a view through this lamp to show you what a cataract would look like. And so when I do surgery, I specialize in surgery of the back of the eye, the retina, but we often have to remove the cataract in order to get a good view to the retina, because again, the retina is behind the cataract. So we will do combined, we'll remove the cataract and then we'll go in and do our retina surgery. But hopefully this shows you a view of what you'll be able to see through a slit lamp if you're curious. And then this other view here, this is still with the slit lamp. Now, remember we talked about looking the back of the eye through that little lens. So that lens is called a 90 diopter lens. This is what your view looks like. So you have this little slit of beam, that's your light source. It's really small. And this red reflex that you're seeing, that's the retina. The retina is red and vascular. So now you're looking at the retina here, there's veins and arteries. They're scanning through the retina. That right there, that circle, that's your optic nerve, which again connects to the brain. This is where glaucoma forms. So this would be your view when you're looking in the back of someone's eye. So again, you can really just right there in clinic be able to visualize a patient's symptoms and their pathology, and you get to look inside an organ with your own eyes. It's pretty cool, and see part of the brain. So yeah, that's what that looks like at the slit lamp. And then this last video, this is through that indirect. So that headpiece that I was talking about, and then hold the lens, this would be your view of what that looks like. So you're holding that lens in front of the eye. This bulge here, this is just because the video is doing it. It's called scleral depression, fancy term, but they're using a special tool called a scleral depressor, or you can use like a Q-tip, and they're pressing on the sclera, so the white part of the eye, and kind of pressing on the retina. This is looking for like any retinal tears or detachments, but that's what your view would look like if you're using that indirect with the lens to look at the retina. These are all normal exams. So wanted to show you guys that because a lot of people are like, what does that look like? And hopefully that was helpful. They look easy to do, but they're not. It takes a lot of practice. Okay, so any questions, or can we move on to just conditions that I see really commonly?
No, in terms of the chat, no specific questions.
Okay, perfect.
Everything is good, so you can continue with the call.
Okay, so I work in comprehensive ophthalmology, so just you're kind of a general across all the board of ophthalmology, but then I also work in our retina department, so we specialize in the back of the eye called the retina. So I'm going to talk to you guys about two conditions that I see very commonly called macular degeneration and diabetic retinopathy, so people who have eye conditions from poorly controlled diabetes. But I think in order to understand those, you need to know what normal looks like in order to understand what abnormal is. So this picture here on your left, this is a picture of the back of someone's right eye. So a normal fundus photo of the right eye. Here's the retina with all its veins and arteries. Here's the optic nerve. And here, that area, this kind of dark circle, that's called the macula. So again, the macula is in charge of the center part of our vision. This is a healthy, normal eye. Now, a common imaging technique that I order in clinic is called an OCT. So it's a fancy term. It stands for optical coherence tomography. But basically, an OCT is scanning the back of the eye and turning then the image on its side. So you guys know when you cut into cake and you make that slice into a piece of cake, and when you pull out that slice, now that you've done that, you get to see all the layers in the cake, right? You guys following? So that's what this image is doing, is you're scanning the retina and now you're turning it on its side. And now I get to look at all the layers in the retina. So this dip here, that's a normal dip. That's called the fovea dip. So again, on the macula, there's this part on the macula called the fovea, and that's in charge of the center part of our vision. So this is a very normal, healthy looking image and scans of the back of our eye. These are going to make sense why they're normal when you're going to see what abnormal is here in a second, okay? So two conditions that I see here. The first one, we'll talk about macular degeneration. There's two types of macular degeneration. There's a dry kind and a wet kind. Layman's terms, the dry kind means there's no fluid, there's no bleeding, there's no swelling. Wet kind, there's fluid, there's bleeding, and causes swelling. So you guys probably have some family members that had macular degeneration, or like any grandparents who maybe lost their vision, because treatment for these conditions is, and like perspective, is really recent. Like my grandmother, she went blind because of this, but now we have things that can treat it. So it's kind of a newer treatment, which is pretty fun, and that we can prevent a lot of vision loss. So the dry kind here, you guys see this picture. This is of the left eye. See these like yellow deposits? Those are called drusen. It's a very common finding in macular degeneration. And then here, see this like big scar tissue over the macula? That's called geographic atrophy. So a fancy term, but atrophy means like death. So the tissue died. So when you look at these scans, here that dip, they have a normal foveal dip. So they still probably can see pretty good. But see on this one, there's no dip there. See like the scan, how much light is passing through here too, compared to up here in normal, where there's none of those, the light doesn't really pass through. See how it's kind of nice and smooth? Where over here on this one, this scan, that's corresponding to this scar right here, all that light passing through, that's because there's no tissue there. So the light just goes right through it. So this person has really poor vision because again, the macula, that helps us see centrally, and they have this big scar over their macula, they're blind, they can't see. Now, the wet kind, they have similar findings with the drusen and the scar tissue, but they also have bleeding. So here you'll see these pictures with the drusen and see all that blood there. Now look at their scan. See these little pockets here, those little like black pockets? That's fluid from the blood and from the swelling. So underneath the retina, subretinal fluid, they get this swelling of fluid. That can lead to permanent vision loss, but this is what we treat. And I'm going to show you the procedure that we do to treat these and to get rid of this fluid. So we don't want fluid. Now, some patients will start with the dry kind and convert to the wet kind. Some patients will start with the dry and just stay with the dry kind. The dry kind, we just treat with high dose vitamin therapy. But then the wet kind, we do these injections. And again, we'll show a video. So kind of getting some nitty gritty, I won't get into all this, but risk factors, that's what RF stands for. If you're over 50, if you're a smoker, if there's a family history, if you're Caucasian and you're female, macular degeneration is the most common cause of permanent legal blindness and visual loss in the elderly. So that's a very common condition. Again, the two types, you have the dry and the wet. These are some exam findings that we just talked about. I mean, I can get into some of the nitty gritty, but basically that fluid, that bleeding is called neovascularization. So neo meaning new and vascular vessels. So new blood vessel growth. And these vessels, they secrete, this is getting really nitty gritty, but they secrete this factor called vascular endothelial growth factor. And that's bad for the eye. It's not healthy. So when you understand that, the treatment makes sense because the medications that I use are called anti-VEGF. So anti-vascular endothelial growth factor. In other words, we don't want it. So we're going to give it something that is anti that. Symptoms, again, are bilateral or unilateral, but most commonly bilateral, blurring or vision loss of the center part of the vision, because again, it's central. And then a really common one is called metamorphopsia. So fancy term, but that's where if you have them look at a grid called an Amsler grid, it's a grid that's just a white outline with a bunch of black lines and little squares, kind of like when you're in math and you're doing like a graph paper. And the patient will say that none of the lines look straight. They're all wavy or distorted. That's a common finding. The test that you'll order in clinic is an OCT, which we showed earlier. And then I also do what's called an FA, so a fluorescein angiography. So that is where I inject fluorescein dye in the patient's vein. And right there in clinic, we get to watch the dye and see how it travels inside their eye. And we take pictures of that. Again, treatment for the dry kind is with the high dose eye vitamins, so zinc, vitamin A, etc. The wet kind, we do these injections of these anti-VEGF. So these are actually, you guys, if you're in oncology, you'll recognize these. These are common chemotherapy medications. And then we also do lasers. So here's an example on this OCT, this imaging of how effective these treatments are. So see how this patient has that pocket of fluid there? Their vision is 2400. So that means that they can only see the big E on an eye chart. When we inject that medication, look how smaller that area of fluid got. We inject it a month later, their vision improved from 2400 to 2100. We inject it again, they came back another month later, they're now 2040. So almost seeing perfect 2020, that fluid's completely gone. And you now kind of have a return of that foveal dip. And then they kind of stay at 2040. And when you do these injections, you always try to inject and then extend treatment intervals. So like I'll inject and I'll see a patient in 4 weeks and then I'll inject again. And if they respond well, I might try to go out to 6 weeks and then 8 weeks and 10. And I keep trying to go out less and less so they don't have to have as many injections. But like here you can see this patient, they went from 5.5 months to then 8 months and then the fluid came back. So you would kind of know that they can't go any longer than 10 weeks because the fluid returns. So then we inject it again, it went away. So that's kind of how these treatments work, which gives you an insight into the field. Ophthalmology is very more elderly patient population. I mean, there is pediatric ophthalmology that specializes in just children, but a lot of the conditions are more in the elderly population. And then two, you have a lot of continuity of care with patients. So I truly do see my patients like some every 4 to 6 weeks. So if you like that type of thing, a lot of people like that for primary care, and that's kind of cool where I don't feel like I gave that up by doing ophthalmology. It's not like I see them once and I'll never see them again. I see them very frequent. The other condition I commonly see is called diabetic retinopathy. So poorly controlled diabetes can affect the back of the eye. This is in all ages. Like guys know, not even joking, last week I saw a 25-year-old who doesn't control their diabetes, 25, and she's already legally blind in both eyes. She can't even read the eye chart. She can't even see my hand waving in front of her. She can just see me shining the light. That's how like sad this condition is, because if you're a type 2 or even a type 1, if you just kind of took care of your diabetes with your diet and worked with your primary care, we could prevent a lot of this. But a lot of patients don't, and so they need our help. There's 2 types. I'm not going to get into all this because this is a lot, and for the lack of time. But basically, you can either have what's called non-proliferative diabetic retinopathy with or without macular edema, or you can have proliferative diabetic retinopathy with or without macular edema. The difference between non-proliferative and proliferative is proliferative by definition means there's either what's called a vitreous hemorrhage, so the gel in the back of the eye, the vitreous is bleeding, or there's what's called that neovascularization, again, those new blood vessel growth, and that would then need to be treated with those injections. Same thing like the macular degeneration. I'm going to show you pictures. These are all physical exam findings, and I'm going to show you pictures just for sake of time and complexity to show you what that looks like. So this first picture is, see all these white dots? That's from the laser. So in clinic, we will do laser where they put their chin in that chin rest, kind of like at that slit lamp, and I zap a laser in their back of the eye. And this basically cauterizes the tissue, and this helps prevent any bleeding. And so this is now permanent vision loss. So I'm actually basically sacrificing the patient's peripheral vision in order to maintain their central vision. But you can still see they still have a lot of bleeding in the back of the eye. Here's some more photos of diabetic retinopathy. So these are called exudates, that white area. These dot and blots, these are hemorrhaging. So blood flame hemorrhages are where the vessel looks more like a flame. These cotton wool spots, you'll see them on exams. You also see this in uncontrolled high blood pressure. They're like really fluffy, almost like feathers in a pillow, and they are on the exam. So what I showed you earlier in videos were normal exams. This would be like an abnormal findings with all this blood and diabetes and stuff like that. Then these pictures here will show you that proliferation. So remember how I talked about proliferative was that new blood vessel growth, and those new vessels secrete that vascular endothelial growth factor, and which is why we do the anti-vascular endothelial growth factor medication. So see on this optic nerve, which is what again connects to the brain, see all these vessels, those clearly aren't supposed to be there. If you guys remember what normal looked like, which is way up here, here's normal. So again, imagine seeing this, and then your next patient is this. Like, anyone can tell me that's not normal. All these new vessels, they're not supposed to be there. Those vessels are being grown because the patient's original vessels just aren't working well because they're not controlling their diabetes. And so the body tries to compensate by creating new ones. But again, those new ones are bad because they're secreting that VEGF. So I need to inject medication to get rid of this. Here is that vitreous hemorrhage. So a patient, that vitreous gel, they have this huge bleed. This would be a common retina surgery that we do. I do twice, 2 days a week in surgery. I do this surgery. I just did one on Tuesday. Again, what I mean by that is I'm assisting the surgeon because I'm a PA. But we go in there, we remove this vitreous and we suck this out because it's blocking their vision. Your patient basically sees a black cloud in their vision. So I'm going to show you a video of the injection that we do. Some people, this might be squeamish to think that I'm injecting a needle in someone's eye, because again, we're trained to not even go near our eyes, and now I'm putting a needle in someone's eye. These videos aren't exactly how I do it, so I'm going to pause and kind of explain how I do, but they should give you an example of generally what it looks like. And then just a couple key points. So in ophthalmology, like, I love that even though I'm in a specialty, I don't feel like I gave up my general internal medicine knowledge, because I deal with diabetes all the time. I see results from high blood pressure. I have diagnosed on an eye exam rheumatoid arthritis, metastatic cancer, Sjogren's disease. What else have I diagnosed? So many, like my mind just went blank. We talked about herpes, like a lot of genital, like sexually transmitted disease can occur in the eye. I've diagnosed multiple sclerosis, melanoma. The second most common location for melanoma after the skin occurs in the eye. So just because you're doing a specialized medicine doesn't mean you're going to give up all your other medicine. And that's one thing I enjoy, because I know that's a fear for a lot of people when they do specialty, is they feel like all that training they spent doing basic, the primary care things, they gave up a lot of that. In ophthalmology, I don't find that. The common cliche saying is the eye is the window to the soul. Honestly, it's pretty true. The eye has been very commonly the first thing to tell us something else was going wrong in another part of the patient's body. So it's a really fascinating field where you're saving vision, restoring vision, preserving vision, but also in some ways saving life, because you're diagnosing something that we didn't know was there and it's affecting the eye, even though it's coming from somewhere else. Okay, so let's get into these last videos here, all right? Now, this first video is going to be of an injection of those medications to get rid of that fluid. So here, I'll pause. So this patient, this gray thing here, that's called the lid speculum. So a lot of patients are always like freaking out, like, oh my gosh, you're going to put a needle in my eye and I don't want to blink. So I put in this little lid spec. It's basically a little eyelid holder. It forces their eye to stay open so they can't blink. This yellow staining that you see, that's called betadine. That's to sterilize the eye. So I'll go over kind of my order of how I give the prepare like a patient for their injection. So patient comes in, I'll do a drop of what's called proparacaine, which is a numbing drop. I'll do a drop of betadine, and that's to prevent any infection and just get rid of any bacteria in the eye. Then I will do what's called a subconjunctival block. So fancy term, but subconjunctiva. So again, the conjunctiva on the eye, I'm going to inject numbing medication underneath that. And I have a video that shows you that. That's then how I'm going to numb the eye. I wait like 5 minutes. Once that's done, I put in this lid holder in the eye. Then I will put, you'll see in another video, I'll mark the eye with the end of a 1 millimeter syringe. And I mark because that tells me where then to put the needle. And then I put a drop of the betadine, which you see here, that yellow, and that kind of is, again, one last prevent infection. And then you see here, they're going to take the needle and they're going to inject. So you'll watch the video here. So injects the needle right in, and then he uses a two-hand technique where he takes, so one hand is putting the needle in their eye and the other hand's taking over and pressing the syringe in. What they don't do in this video that I do, and I think you'll see in the other video, is when I pull the needle out, I have a Q-tip. It's a sterile Q-tip. I get it wet with balanced salt solution. And as I pull the needle out, I put the Q-tip right over where I injected. And that's to prevent anything to kind of what's called like prolapse, any of the medication or the vitreous gel to kind of come out. I also do that to help prevent bleed. So it's called like a tamponade. They don't do that here. Some people don't, but I think it's helpful. So we'll kind of do it one time all the way through. So boom, and they go in and done. It's super fast. People are freaked out. You guys, like, literally, I'll do, so I don't see that many patients a day because the practice I'm at is not about like high volume, which is really nice. They're more about just like spend time with patients, have quality. But I have come from a clinic where we were doing like 50 of these a day. So it gets very normal for patients because they get them every 4 weeks. Now this other video, this kind of shows you more longer, and I'll explain what they're doing. So they're using a drape over the eye. I think that's kind of extra. They're just doing that prevent infection. They're putting this lid spec in right now. So that's kind of how it works. The other thing too, what you do is you have the patient look up in a direction. So the way I do it is called infratemporal. So what does that mean? Well, I inject inferiorly from down here and temporally. So this would be nasal towards the nose. This is temporal towards your temporal temples. So I have the patient, if it's their, this is my right eye, but I think it's probably your left on the screen. I would have the patient look up. If it's the right eye, look up into their left. If it's the left eye, I have the patient look up and right. And hopefully that makes sense now. When I do that, I'm going to take the needle, inject infratemporally, again, inferior temporal. You could do it supratemporally, supranasal, infra, it doesn't matter, but you need to have them look in one direction. And that's to prevent the needle from hitting the lens. Because again, anatomy, this injection is called an intravitreal injection. I'm injecting it into that vitreous space that we talked about in the back of the eye. So I don't want to hit the lens. If I hit the lens, I could cause a cataract. I could cause the lens to detach. I also don't want to go too deep with the needle. I could cause the retina to detach, which is like an emergent surgery that could make the patient permanently blind. So this is it looks easy. Well, maybe it doesn't look easy, but it's a lot of complications if you don't do it right. So they put the lid spec in here. Here's the subconjunctival block that I talked about. So you're going to take a needle. I've used lidocaine 2% without epinephrine. And I take the bevel up, and you'll see here, see that needle right there? And now he's going to move the needle along the conjunctiva. This is to help get access. This video shows it looks easy. It's now easy because I do it enough, but guys, this is like, literally imagine for the first time you're taking a needle towards someone's eye and they're not numb yet. And you're trying to touch this thin piece of tissue and your hand is like just shaking. It's like it's so scary because it's near the eye. And if the patient looks or you accidentally go too deep and they're not numb, but you'll see gets underneath the conch here. So he's moving the conjunctiva, or she, I'm sorry, I don't know why I'm saying he, it could be definitely a female. And
So,
now he's underneath. So now he's injecting. So then what you do, you eject and see that little elevated area, that's called a bleb. So he just injected numbing. And this is what I do to numb the eye into where I'm going to inject. So then I just wait 5 minutes here. Once I do that, I then put the lid spec in. So they've already put the lid speculum in. Patients find that to be kind of uncomfortable. So I wouldn't put it in yet. I would do it after they're numb. And then what I would do is I would take the syringe. This is a Q-tip of betadine. Again, I would have done that before, and I don't do it right now. But so here you're seeing the end of a 1 millimeter syringe. The patient is looking up into their right. So this is probably the left eye. And their also approach here is infratemporal, because here's the nose and here's the temporal. So they're doing it how I would do it. You're going to mark at this border here of the iris called the corneal limbus. And you're going to mark here with the end of the syringe. You press in, it makes the indent. What I do then after that is I put a drop of the betadine. They're using this little Q-tip, and you'll see the Q-tip doesn't really work, but I do a drop, one to, again, prevent infection. But the betadine really kind of paints over that, and you can really see the marking well. You'll see here when they dab, you can't really see the marking at all. But when you do an actual drop, you really see the marking really well. And that is, again, your kind of sweet spot when you inject. Then they're going to, the patient moved, but you have them look up again. It should go through here in a second. Okay, so they're just sterilizing one last time. They're kind of taking their sweet time. Okay, and then here's the injection. So here's going to show you the concept that I do, where I inject the needle. Once I go in, I use my other hand, and I two-handed technique. I press the medication in. With the same hand, I have a sterile Q-tip that's been wet with BSS, balanced salt solution. When I pull the needle out, I use the Q-tip to put right over it. And that's what they're going to do here with this Q-tip. And again, that's to prevent any bleeding or any of the medication or vitreous to come out. So they're injecting. They're going really slow. You want to do this as fast as you can. And then he's going to take the Q-tip, or she, and pull out, and done. And that's it. And then you remove the lid spec, and then you basically rinse out the patient's eye with BSS, it's called, balanced salt solution. And that's because the betadine is very, let's see, so I'm going to go back to full screen on the video, okay?
okay. Oh, that was really cool. So I don't know if you mentioned, but how far did you go into like the needle? How
far do you go in?
Yeah.
Yeah. Okay, so the needles that I use a 30 gauge. So it's like the 32, I think, is the smallest. So a 30 is the next. So it's a really small needle. And the needle then is a half. So typically, like if you're drawing up a medication, the needle will be like that long. These needles are only like that long. And honestly, if you went all the way to the hub of the syringe, so the end of the needle, you still would be fine. So you could go all the way and like you're not going to cause any damage. But I think I do about 3/4 of the needle, but it's not a full needle. It's like a half of a needle. And then I do about 3/4 of that.
Okay.
You don't want to go not enough, because then you could inject the med not in the vitreous, but in like the choroidal space, it's called, and that can cause an infection and stuff and more harm. So you do want to go in and make sure you're deep enough, but you also don't want to go in too far and cause a retinal detachment. But typically you're only going to use that much of like a needle. So yeah. Hopefully you can see me now at a wider view, because I'm done with the lecture and video sharing and stuff. If there's any questions on any of that, feel free to chat. What I was finishing was I rinse out the eye, and that's because the betadine, that red drop to prevent infection, it's really burning for patients, and it's really itchy and bothersome when the numbing wears off. So I really rinse that out, and so that way they don't have to deal with that afterwards. So, okay, any questions about what we talked about what to do if you're in high school, and like kind of what to set you up for a career in healthcare, whether that's med school or PA school? Any questions about PA school, either applying, during, whatever? I'm happy to answer anything. So,
okay. So let's go into the topic of PA specifically, and like, why would you choose PA and not MD?
Okay, yeah, good question, you guys. So I battled this question myself, so I totally get it. I did PA school for a couple of reasons. You probably heard them before, but I think they're pretty valid. I always wanted to do medicine, so some of you may relate to that. but, and this is going to sound bad, but medicine isn't the only thing in life. In other words, like that's not the only thing I want to do. I enjoy other things. And so PA kind of embraces more of that lifestyle and that mentality. So you go to PA school, it's a master's program. So you have to have a 4-year bachelor's degree. And then it's a 2-year master program. So you're only doing like 6 years of post high school education. Whereas med school, after your 4-year bachelor's, you have 4 years of med school. And then let's say you're interested in ophthalmology, then you would do a 4-year ophthalmology residency. And then a lot of ophthalmists will do a fellowship where they specialize in a part of the eye. And that's anywhere from like 1 to 2-year fellowship. So that was 4 years of undergrad, 4 years of med school, 4 years of residency. We're already at 12 years, and then a fellowship, like 13 years of post high school training. Whereas I was like, or I could do 6. Like, I think I'm going to do 6. Just because I knew that I could do ophthalmology as a PA, even though it wasn't commonplace. I just was like, I'm going to do this. That said, during PA school, I loved all of it. So like, even if you go in the mindset that you're interested in a specialty, there was fields that I would be happy in. I loved OBGYN, emergency medicine, family medicine. I loved a lot of it. So it's not that you only have to pick it. And that's the other reason why I picked PA is I don't have to pick a field. Anytime in my career, I can change specialties. It doesn't matter. You don't have to go back to school. And that's kind of what I did. I did family medicine first and then went to ophthalmology. So that was the other benefit. The other reason I picked PA, less debt. Honestly, you guys, like, it's a real thing to consider. I mean, you have 2 years of school after college, but a lot of medical students and then residents, you come out with a lot of debt, and then you're now in your mid 30s, starting kind of your life and your career, and then you're now paying all that back. So there's just more in life than medicine, and it's kind of nice to start doing like retirement saving and all these things that they don't teach you in school that are so important to do in your 20s when a lot of other people do it. So yeah, that was why. And then the other big reason, honestly, is PA demands you to do medicine before you commit your life to it, because you have to have hours of experience. And a lot of us probably relate that we always want to do medicine, but we've never actually done it. So how do we know we're actually going to like it? And a lot of my PA school is at a med school. And so I was with a lot of med students, and I heard all the time, like, I don't want to, and I'm not this, I don't want you to hear that I'm downing med school. Truly, I always tell people this: if you want to go to med school and be a doctor, do it. I have nothing against it. I can just say my experience. And I heard a lot of med students who never did medicine were like, I don't like this. But then they felt stuck because they already kind of committed so much money and so much work to it that they felt like they had to finish. And that just leads to like burnout and depression and all these things that we see post-training. So whereas PA school, you're kind of expected to do it before you commit to it. And you kind of know then better what medicine actually is in real life versus just in your imagination, if that makes sense.
Right. And PA, as a PA, it is a very well paid job. It is also one of the most growing jobs in the healthcare field. So it is something, if you're interested in the medical field and you're not sure that if medical school is right for you and going in residency and you don't want to spend the 12 years, but you still want to work in the medical field, this is a great job to work as and get started in that. Another question that has been popping up a lot is, what did you major in college? And if you want to tell us a little bit about where you went to college too, that would be
for sure, you guys. So I actually got some DMs about this, and so hopefully this will address it here. So I did pre-med. I did the degree, and you do your organic chemistry, physics, all your biology, everything to set you up for med school, PA school, all the above. Now, looking back retrospectively, what I always tell people is it doesn't matter what your degree is as long as you have the prerequisites for school. And you probably have heard this, but it's so true. The nice thing with a pre-med degree or something science-based is a lot of the prereqs are built within the degree. But if you could do a degree, say like Spanish or something, if that's your interest, and you study Spanish, which I now like, that's what I wish I did. And then I just took all the prereqs within my Spanish degree as like my electives, I could still apply to med school or PA school, because all they care about when you look at applications, it's just going to say a bachelor's degree from accredited college. And then they're going to list their prereqs. It doesn't tell you what degree you have to have, as long as you just have these prereqs, which are typically like anatomy, physiology, micro, general chemistry, organic. So yes, a lot of people do pre-med because that's built within the degree. But truly, it doesn't matter what you do as long as you have those prereqs. A lot of my PA classmates were like in their 30s, 40s, second career. A lot of them just like got a business degree and then just took the prereqs out of community college, that type of thing. So it doesn't matter what your degree you have as long as you have the prereqs. So maybe it's early for some of you, but if I was you, I would look at the schools that you might be interested in applying to and see what their prereqs are and just write a schedule down and then make sure your degree has those. And then you can study anything you want.
Right. So if PA is a field that interests you, what your first steps would be if you're an undergrad, I would look at what PA schools they're in your state or what PA schools are near your state and see what kind of requirements they have and to see how that fits into your major. But you can, like so you said, you can pick any major you want and you should pick the major that best interests you, whether that be business, whether that be Spanish, whether that be English, it could be anything. But as long as you meet your prerequisites within your major that are required to that are required to enter into PA school, you're good. So any major is okay.
Exactly. 100%. Yep.
Okay. There was a question about switching between specialties. So can you talk a little bit about how that works and how you can switch between specialties or?
Yeah. So as a PA, when we graduate as board certified. Well, then you take a board exam, which we have to take every 10 years. You're a board certified physician assistant and you don't pick a field. So unlike when you go to medical school and you graduate med school and then you go to a residency, when you pick that residency, you're picking kind of your field that you want to practice in for the rest of your life, unless you want to go back to school. So if you hear like of an OBGYN doctor, well, they did med school, they picked an OBGYN residency and now they're an OBGYN. Whereas PA school, you do a PA school and you just graduate, you don't pick a field. So when you apply to jobs, you could see jobs for a PA in commonly primary care, so like family medicine, internal medicine. You could see patients in specialties, PAs like urology, dermatology, orthopedics, neurology, interventional radiology. They're in honestly pretty much all fields. Some are definitely more commonplace. And so what that looks like in the real world is you apply to a job and you do it and you just work the job and you just do the job. And then if you're ever like, oh, I'm kind of bored or I'm really interested in this, well, if there's job openings, you literally just apply for that job. And if you get it, you get it. You don't have to go back to school. You don't have to do it more training. There are fellowships for PAs. So you can, after PA school, go to a fellowship program. And those are typically for like emergency medicine or orthopedics, if you want to more subspecialize and get more formal training. But truly, most jobs, a lot of PAs after school, and if you're transferring from a specialty that you don't maybe have experience in, a lot of it's on the job training, or you just kind of already know it. So I would say like coming out of PA school, you get pretty acquainted with like the fields that most prepare you after PA school is more your outpatient, like primary care, or like emergency medicine, urgent care, general surgery, because there's rotations in PA school that you're required to complete. And then you get electives, but you're required to do family medicine, psychiatry, which is inpatient and outpatient, general surgery, pediatrics, OBGYN. Sorry, guys, I'm like trying to remember them all. Inpatient, like hospitalist medicine. I think is there more? I think I may have gotten them all. Anyways, you have these core ones and then you have electives. So then you can kind of choose other ones you want. But those core ones, those are ones you kind of come out most prepared for. But truly on the job, if you're changing specialties, a lot of it's just on the job training.
Okay. Question that has popped up a lot is there's a lot of high school students in our audience.
Yeah.
So what would you recommend for them in order for them to be set up for PA school? Would it be like a similar situation for just getting involved in the healthcare field and kind of like picking? But I'll let you answer. What would you do as a high school student? You set yourself for PA if that's what you're really, really interested in.
Yeah. Okay. I'm glad this is geared towards PA just because that's what I feel like I can answer. So I'll share with you what I did and then what I would recommend. So I started college at 16, and then I did the 4 years, graduated at 20, or it's like 19. And then I went straight, worked in an eye clinic, got my years of experience. Most PA schools, you need like 1,000 hours of experience. Some require more, like 2,000, some require less. but you don't want to be a minimum applicant either. But it takes, I mean, that's a while, it takes a while to accrue that many hours. So plan on having a gap year or two after undergrad before PA school to get those hours of experience in order to then apply to PA school. So then you apply to PA school, and then the application process is about a year long. So then you're applying and working while that, and then you start PA school. So to prepare for all of that, what you need to do, I actually help with like interviews and admissions. PA schools will want letters of recs from either like professors or MDs, DOs, and PAs. Some PA schools will say a PA is optional. It's not. Don't listen to that. You have to have a letter of rec from a PA, hands down. So definitely shadow a PA. The other thing they love is volunteer experience. So if any of you do like mission work or anything like that, really jot down your hours and write down what you do. Anything you come up with volunteer, they love. So volunteer experience, shadowing, other letters of rec from like an MD, a DO, and then obviously you're going to need to work in healthcare in some capacity to get hours of experience. You could start that in high school if you want to. Like go work in an eye clinic and do that while you're in high school and start accumulating hours now. And then maybe you could go straight from undergrad to PA school if you've already done your hours. Some people do that. That's maybe looking back, like maybe I would have done that. I always just did like random odd jobs in high school. Now I'm like, oh, maybe if I did something medical as a high schooler, then I could have gone to PA school faster. But then I'm also like, I don't really care though that, and I'm like, it's fine. Like, don't rush it. Enjoy your younger years, But potentially you could do that. You could go to like become a CNA or an MA, a medical assistant, or, some other training program that you do while you're doing your high school. And you graduate with like a certificate. And that could be your entry level job into healthcare and way to get your hours. And you could do that as a high schooler. And then I wouldn't say PA school is super heavy research based. Like, don't feel like you have to have a lot of research. I did have research, but honestly, a lot of my classmates didn't. So if you have it, great. If not, I wouldn't say it's the worst thing. And then let me think, what else? Yeah, I guess to summarize, as a high schooler, I would focus obviously good grades. Like, you're going to have all your college friends or classmates who are like always thinking you're overstudying, but they don't realize that you're applying to really competitive programs that really want high GPAs. So get those A's if you can, and then have shadowing hours, healthcare experience, and volunteer. 100%. 100%.
That's the core. We're running low on time, so we will take a couple more questions and wrap it up. Can you talk about so you graduated at 19 and then you took you said 1 year of gap year, and
Yeah, it
then
was like a year and a half.
year and a half, and then so at what age were you a fully a PA?
I was 20. Let's see. I was 24.
So you're 24 and you were a PA. So right. And another thing is
which, like, and guys, don't feel like that rushes you. Like, literally all my other classmates, there were some a couple years older, but majority were in their 30s and 40s. So PA school is more designed for the people who've been in healthcare for a while, and it's their like second career, and they're a little old to go to med school. I was definitely on the younger end.
Okay,
go ahead.
Another question that I see is about the entrance exam. So could you talk a little bit about the entrance exam and what you did for that?
So if for PA school, there isn't an entrance exam. Some require the GRE, and that's just if you're going to like any grad school program, some will require the GA, but some programs don't require it. So that's a way to trim down your programs. If you don't want to take the GRE, like I was one, I'm like, I don't do well on standardized exams, so I didn't take the GRE. So I just didn't apply to PA schools that required it. Some PA schools implement what's called the PCAT. So just like the medical school has the MCAT, the PA school now has a PCAT. Only a few require it. So for me, if I was you, I would just feel like I'm just not going to apply to those schools and not take it. So there's no entrance exam for PA schools in the sense that you can go to schools and avoid that. The only ones though there would be a PCAT or a GRE, but there's so many other schools that you could apply to that you could avoid that altogether, like I did.
Right. I mean, so there's no set exam, and you can find programs that are, as long as you have your bachelor's and as long as you have your prereqs and you do well in those classes, you can apply straight from college to PA school without taking the test, but there might be some schools that will have it, but that's up to you to decide if you want
Exactly.
to take it.
100%. 100%. So figure out your algorithm right now, you guys. Look at the prereqs, what schools you want to go to. I'd say like pick 5 or something. PA school is really competitive. Like, I don't want this to sound like it's not. It's extremely competitive to get into, extremely. But look at the top 5. Look at the prereqs, how many hours of experience they require, how many shadowing hours they require, letters of rec, the bachelor's degree, and then if they require any additional things, and then you just determine on your own if you want to go there. So that was my way to trim it down. I was like, I'm just not going to take any entrance exam. So now I can knock off all these other programs.
But with that being said, there's a question I see is like, what would be a competitive GPA to enter those? And would you say the schools that don't have the requirement, would you need to show that in kind of like your GPA and kind of shine in like the extracurricular activities? So what would be competitive GPA? And
yeah, good question. So truly try to be a well-rounded applicant if you can, and don't be a minimalist applicant. So I see this a lot when we're looking at admissions, is like, say the school requires a 3.0 GPA overall, and then any prerequisite, they'll be like a C+ or above. And like your applicant is a 3.0 GPA and they got all C+, and maybe they require 500 hours experience and the applicant has like 500. And it's very like, okay, they meet the requirements, but it's the minimal. But then your other person you're interviewing has like a 3.5 and B's and A's and maybe 1,500 hours. So don't be a minimalist. But I would say competitive GPA is, look at, okay, so every PA schools, they're required to post this. They will post the like data of their current class. So they'll write like the average GPA of the incoming class. So let's say the average GPA of the class was 3.5. Well, now you kind of know that that school is kind of expecting something in that range over overall GPA. So that's kind of your way to know, like, am I going to meet them? I found like in my program, my GPA was a lot higher than the most of my class. I had like a 3.9, but a lot of my classmates were like 3.0. But then their hours, because I was so much younger, they had like 10,000 hours of healthcare hours and I had like 2,000 something. So I was higher here, but they were higher in other areas. So if you have a stronger part of your application that can kind of pull up a weaker area, that's just really true way. So focus on not being a minimalist applicant, but don't freak out if you don't have a 4.0, because you might be stronger in other areas.
Okay, correct. Yeah.
But look at the school. They're going to post it.
Right. Okay, so before we go, we're a little bit over time. One really quickly closing statement. One last piece of advice for students who are joining us. What would you recommend? One thing that they should get into, or any sort of advice for that before we close it out.
Okay, this is gonna sound really cheesy, but honestly, have fun and worry less. When you love something, you don't keep it to yourself. You're gonna share it with other people. And truly, like, that's why I'm on here. I didn't have anyone helping me throughout all of this. And one day you're going to be on this end of it and you're going to be able to help people. So just have fun, worry less with it. It all truly does work out. And don't let medicine change who you are. Just let it kind of enhance who you are. It's a very challenging field, but honestly, very rewarding. So, yeah.
With that being said, I want to thank you, Joel. I mean, there was a lot, you provided a lot of great advice for a lot of students. You answered a lot of questions, and I want to thank you for taking the time to speaking with us and with everybody. And also a couple more things. We run this program free for all of you guys to come in. But with that being said, we still have costs that are associated with the program. So if you can donate in any amount, no set limit, you can donate whatever you can. And that'll support us with our email server that we send out reminders to. So if you're new and you haven't signed up for that, you can click on the link in the Instagram bio and you can sign up for our emails. And we send an email every week regarding what our call is going to be, at what time, what date, and what field is going to be. So if you found that PA something that you like, and this is you, I mean, I hope that you found a lot of important information from Joel. But if you also want to kind of get information from other fields, we do call across the board with MDs, DOs, PAs, nurses, everything. So you can come into future sessions, and we also have calls that we've already done, and you can watch those. And those can also, if you watch those calls and send us in your summaries, we can verify those. And all information regarding the summaries, like I said before, is posted in the Instagram bio link tree. Check it out and review those guidelines, and it'll explain everything there. And other than that, if you can donate, our Venmo and Cash App information is put up on the screen, as you can see, Club Med Shoe, Club Med Shoe. And there's that. Please send us anything you can. And if you have any other questions regarding Joel or us, I have put Joel's Instagram on this screen.
Yeah, you guys can DM me. I'll answer.
All right. And then you can follow him too on Instagram. And then if you have any questions, you can DM us on Instagram or you can email us. Thank you.
All right. Thank you guys. Have a good night.